Hey everyone, and welcome to The Explainer. Today, we're digging into something huge, the brand new 2025 AHA guidelines for hypertension. And let me tell you, these aren't just minor tweaks. This is a big deal, and it's absolutely going to change how we handle those crazy high blood pressures we see all the time. So let's jump right in with a classic case, one I'm sure you've seen a dozen times. You've got a 48-year-old guy who comes in for something totally unrelated, maybe a toothache. You check his vitals, and bam, 196 over 122. For years, a number like that would set off all kinds of alarm bells. But the question is, what's your move now? Because that old playbook, it's officially out the window. These new guidelines give us a much clearer and honestly a safer path forward for this exact kind of patient. Okay, let's dive into this. Before we even think about treatment, we have to know our data is good. And the guidelines really hammer this home. Step 1, the absolute foundation, is getting the blood pressure reading right. It's non-negotiable. Look, this isn't just ticking a box. This is the stuff that prevents major clinical errors. We're talking about using a validated machine, making sure the cuff size is actually correct, having the patient sit quietly for a few minutes before you take it, and then taking at least 2 readings and averaging them out. It sounds simple, but it can be the difference between an unnecessary admission and a solid, safe discharge plan. And here is a really critical, really direct warning from the AHA. Those cuffless wearables, like the smartwatches that people love, they should not, I repeat, should not be used to make a diagnosis or to manage treatment. While they're cool tech, they just don't have the validation we need for clinical decisions. So for now, they are a hard no. All right, so you've confirmed the number is real. The blood pressure is truly high. Now you've reached a massive fork in the road. And the new guidelines make it super clear. There is one, and only one, question that decides which path you take. This is it. This is the whole ballgame right here. The question you have to ask is there any evidence of acute target organ damage? Is that high pressure actively harming the brain, the heart, the kidneys right now? You have to go looking for it. So what exactly do we mean by target organ damage, or TOD? We're talking about acute, life-threatening damage to the big, important organs, the brain, the heart, kidneys, the aorta, that's being caused directly by that severe blood pressure. The key words you got to remember are acute and life-threatening. This isn't about chronic changes. It's about what's happening this very minute. And these are the things we're hunting for in the real world, right? Things like a brain bleed, an ischemic stroke where you're thinking about giving clot busters, heart attack, flash pulmonary edema, an acute kidney injury, or an aortic dissection. If you find any of these, you're going down one path. If everything checks out and you don't find any of them, you're on a completely different and much calmer path. So let's talk about Path A first, because this is the one you're going to see most of the time. This is your patient with that sky-high number, but after you've done your exam and history, you find absolutely no signs of acute target organ damage. Now, what's really interesting about this slide is that it highlights one of the biggest philosophical shifts in the guidelines. We are officially retiring the term hypertensive urgency. It's gone. The new term is severe hypertension. The criteria are the same, BP over 180, 120, but the key is without any acute TOD. And this isn't just about changing words, it's a very deliberate move to stop us from overreacting and overtreating a number. The new mantra is basically this: don't slam them with IV labetalol if there's no target organ damage. We want to avoid those aggressive IV drips and infusions. The goal is a nice, gradual reduction in blood pressure over days, not some dramatic drop in the next few minutes, which can actually cause harm. So instead of an admission, here's the new plan. It's simple and it's safe. First, you start or you bump up their oral meds. Single pill combos are best for adherence. Second, you give them clear instructions on how to monitor their BP at home. Third, and this is crucial, you get them a follow-up appointment within 1 to 2 weeks, not months from now. And finally, you schedule a lab recheck. This works, it's safe, and it keeps hospital beds open for the people who truly need them. Okay, now let's switch gears and go down Path B. This is the true hypertensive emergency. It's way less common, but it's infinitely more critical. This is the patient with the high BP plus clear evidence of acute target organ damage. This situation demands immediate but very careful intervention. The old one-size-fits-all approach is officially dead. The new targets are incredibly specific to which organ is in trouble. Just look at intracerebral hemorrhage, a brain bleed. The new goal is to smoothly bring that systolic down to a tight window of 130 to less than 140. And this is key. Avoid going below 130. Or how about for an ischemic stroke patient after a successful clot retrieval? The advice is now to avoid a systolic pressure below 140 for the first day or two, because we've learned that letting it drop too much can lead to worse outcomes. These are huge, practice-changing updates. Okay, I know that was a ton of information, so let's make sure it sticks. We're going to do a rapid-fire recap of the 5 biggest take-home points that you can literally take with you and use on your next shift. All right, number 1.
Hypertension urgency is a retired term. It's now severe hypertension. And if there's no organ damage, the treatment is simple. Oral meds and quick outpatient follow-up. No IV drips, no automatic admission.
Coming in at number 2. Remember, the number on the monitor does not define an emergency. The presence of acute target organ damage is what defines the emergency. It's really that simple. No TOD, no emergency. Number 3. When you do have a real emergency, the BP targets are now more specific than ever. For a brain bleed, you're aiming for that 130 to 140 systolic range. And after a thrombectomy, you want to avoid going below 140. And the 4th point, get the basics right every single time. Good data is everything. And whatever you do, do not use a patient's smartwatch reading to make a clinical decision. And finally, our 5th takeaway. In a brain bleed, remember this: smoother is safer. A nice, gentle, controlled reduction is the goal. You want to avoid those big, drastic drops and wild swings in the blood pressure. So, let's circle all the way back to where we started. That 48-year-old guy with the toothache and the 196 over 122. The next time you see him, you'll know the game has totally changed. Your first instinct won't be to grab an IV medication. Your first move will be to ask the right question: is there any target organ damage? And believe me, that will make all the difference.